diastolic function evaluation in atrial fibrillation. So we know everything is this chart about the diagnosis of diastolic dysfunction in the normal sinus rhythm. And that I'm not going to talk about this. The most important thing is that in atrial fibrillation is the absence of the A wave. So to determine the LV filling pressure by the E by A ratio is not possible in case of atrial fibrillation. What is needed in the atrial fibrillation is like the first picture is that it's the average you have to take because not all the parameters are of the same height and distance. Like in this, if you want to see the height of the mountains in the beautiful bank of the Yangtze River. So this is a case of atrial fibrillation. What you see in a case of enlarged LA and good systolic function, biatrial enlargement, and this is the slide is needed to how to determine the increased LV filling pressure in atrial fibrillation. These are the parameters, but the most important, I'll go into the one parameter one by one. So most important is that you have to take at least 10 consecutive mitral E and the annular E velocities to be average. Or what I do in my practice is that 3 consecutive E or E prime velocities with the variation of the heart rate between 10 to 20%. I'll show you the example. The most important that even the lack of variability is very important factor because EF velocity despite the variation of the RR interval is highly suggestive of increased LA pressure. So if you take the mitral EF velocity in case of atrial fibrillation, you'll get these sort of variability. Either you have to average 10 or you have to wait for these type of picture where there is only 10 to 20% variation is there and take the measurement here. And this variability is reduced in a patient, particularly where there is an increased filling pressure, making it a possible determinant, although it is a quality tape. Next, what are the parameters? First is the DT. If the DT is less than 160 millisecond in patient, particularly the depressed LVF, remember is that. So you measure the DT here is the DT is 131 and other party you can take 130 or 113 like that, all are below 160 millisecond. Second is another important parameter is the peak acceleration time of the mitral diastolic velocity is more than 1900. So if you take the mitral, here is in this case is near about 2600, then you can take consecutive beats, if you take it near about 2100. And next is the IVRT. This is another important parameter you can take. IVRT, you can, same thing, you can average it or take the similar 10 to 20% interval. Here we can measure it, in this case near about 55. Is below that or 50. So first choice to measure the mitral inflow EF deceleration time DT by the pulse Doppler. It is easy. Why? And highly accurate measurement. However, this is only for subject with reduced left ventricular ejection fraction. EF DT is not a good determinant of filling pressure in patient with the preserved LV ejection fraction. So what are the other parameters? Then we take the E by E prime more than 11. So again there is if you take this sort of E prime is not good. Rather this is good one where there is a variability is less. And you can average it both in the septal and the lateral annulus. One is the important is that single bit measurement of E by E prime ratio increase the sensitivity and accuracy of this parameter. Even the single bit lateral E by E prime more than 11 is a good predictor of elevated PCWP more than 15 millimeter of mercury. And next is the PR velocity. TR velocity, if it is more than 2, you take the TR velocity here, and by the way, there is some variability if you can average it. The first illustrated by measuring the maximum tricuspid regurgitant velocity, a good determinant of the filling pressure increase when more than 2.8 meter per second. Same in sinus rhythm. And next is the DT of pulmonary deceleration time of the pulmonary vein diastolic velocity less than 220. So to that, you have to zoom that left atrium, particularly right superior pulmonary vein, take the flow with a little bit of Nyquist limit, reducing the Nyquist limit, and then follow the pulmonary vein Doppler, and then stop it and measure the diastolic deceleration time of the diastolic velocity. These are the things recommended in the American Society of Echocardiography and the AJ. But nowadays, even the VP is very one of the important parameter, is that where you can measure the slope of the VP in the mitral propagation velocity, and you can again average it. It comes to this way and take the mitral propagation velocity. And where E by VP ratio, if you find more than 1.4 or 1.5, it gives a good indicator of LV, diastolic dysfunction, and the elevated LV pressure. Here in cases, if you take the 113 by 41 is more than 2.7 in our case, so that is the LV elevation pressure. LA volume you can do like all cases in the sinus rhythm, but with a little bit of caveat in this, that the way you not know everything, that I am not going to discuss within 10 minutes. But the important is that the second rule for determining the filling pressure in the presence of chronic atrial fibrillation is not to use atrial dimension, because regardless of the measurement type, volume or anteroposterior dimension, indexed or not, its increases does not correlate with increased filling pressure. This is due to the well-known mechanical remodeling induced by atrial fibrillation, which increases atrial dimension regardless of filling pressure. So this is a secondary one. Another important, though it's very small, is you get atrial fibrillation halo wave, that gives a good indicator that probably is dealing with the left ventricular increased filling pressure. Another novel parameter is that you have to the tissue Doppler echocardiographic time interval. What is that? This is the two time intervals are measured, one between the tip of the R wave in the ECG and the start of the mitral E velocity, and another is the tip of the R wave in ECG and beginning of the E prime velocity. And difference of these two time intervals is called the tissue Doppler echocardiographic time intervals. These time intervals taken from 4 annular sites are measured, and average is taken and is more accurate than a single site measurement. And now, if you do the IVRT by T E prime ratio, or IVRT by echocardiographic interval is less than 2, was found to have a sensitivity and specificity of 90% for detecting a capillary wedge pressure more than 15 millimeter of mercury. How to do it? This is the way. Take this R wave to this one, R wave to E prime, and find out the difference, and then is that. So my final slides is that all measurements have good accuracy. Thus, choosing which one to use depends on other characteristics. Tool availability in the software, which may not be available in the equipment used. Reproducibility issues should also be considered, such as the variable using the pulmonary venous flow, pulse Doppler, and the flow propagation velocity. Therefore, I do recommend IVRT and the septal E by E prime ratio continue to be strongly recommended in case of atrial fibrillation. Why? First, for being the simple and practical, and the second for being commonly used in basic protocols. Thank you.